up to New York, starting from Claremont on June 12th. Again, essentially driving about 24 hours straight on an electrical vehicle and stopping at every charging point and having events aimed at raising awareness for men's health. How on earth did you guys think of this?
Well, I got a Tesla car last year. It's an all-electric car, and it's one of those cars that makes you smile every time you step on the accelerator. And Jamin and I both love it equally. And so this started as an excuse for us to drive up to New York, and we have to stop every 100-150 miles to charge it. So we thought, wow, this would be a great way to wrap it around the Men's Health event. And traditionally we do things like for Men's Health Month during June, we do things like free prostate screenings. But the problem is it just doesn't come across as appetizing, and patients actually sometimes run the other way. And so we thought, what if we made this really fun and cool and combine cars, technology, the future, and hey, by the way, take better care of yourself.
And it's a spectacular car. We recently all were at our annual meeting in Orlando for the American Urological Association, and you were kind enough to take me to dinner, and afterwards the Pinnacle, which you drove us around in that spectacular car. And it's an amazing car. It's an amazing thing that it's all electric. So I was kind of blown away for that, and thanks for that. And we didn't get a ticket, so that was good as well.
Well, we were going at the speed limit.
We were for a very short period of time. I mean, it's really, truly a very, very fast. And again, the conversation doesn't condone speeding, so make sure that you drive the speed limit, as I will be doing driving home. So one thing to talk about your backgrounds, both of you are fellowship trained in the most minimal, or I guess the least invasive of all the minimally invasive options. You guys do microsurgery with the robot. So, and Dr. Pergano, you're actually one of the founders of the Ramsey Society, which is essentially the robotic society for minimally invasive surgery and microsurgery using the robot. And you did both a fellowship in laparoscopic and robotics and infertility at the Cleveland Clinic, which is one of the most celebrated places for innovation in minimally invasive surgery, laparoscopic, and robotics, and you got a background as an electrical engineer. So one thing I wanted to talk about, I was asked this, how on earth did you go from engineering to urology to microsurgery, and what were the things that kind of took you from the engineering world to urology?
Well, I've always had an interest in using robotics for microsurgical or micromanipulation. When I was in engineering, I actually had no interest in medicine, was afraid of working with blood, and was really intrigued by technology. So I was a chip designer, and my job was basically doing micromanipulation and testing of circuits with micromanipulators. And so I really thought it was fascinating stuff, and I was a true double E geek, and really enjoyed that stuff. And one of my buddies got into medical school, and I thought, wow, that'd be kind of neat to then maybe I could help out with making instruments or for surgery, and that's what initially got me interested in medicine.
So the possibility of biomedical engineering.
Exactly. And so, when I got into med school, I was lucky enough to get in, and once I got in, we're kind of trying to figure out which way to go, and urology seemed very mechanical. I wanted to be one with the flow, and it was really nice, and I thought it just seemed very mechanical and linear, and so I kind of gravitated towards that. But once I got into urology, I still had that interest in micromanipulation, and so I was really drawn to microsurgery. And I've always felt that technology wasn't quite up to par on the medicine side. In engineering, we have all these new toys and tools that we're using. Now, obviously, in medicine, we're dealing with patients, so obviously there is a lag in testing and things like that. But I thought it'd be great to be part of that process, and so that's what initially drove that interest in robotic microsurgery.
How about you, Jamin?
Well, I come from a different background. I was the pre-med geek at Boston University, and then I actually got into Boston University on an early acceptance course. So I was there in Boston for 8 years, and then I did my residency at University of Tennessee in Memphis. And,
how'd you pick urology?
Why I picked urology is because I actually always wanted to be a general surgeon. And then I did my surgery rotation, and my personality just didn't fit in well. Everyone just didn't seem, as dynamic and flowing and as happy as all the urologists that I was working with were. So I spent about a week in urology, and I decided this is what I want to do. The mix of, medicine, surgery, And, always being on the forefront of technology, that's when the robot was just coming out. And our chairman there was actually one of the first to utilize the robot in the Northeast. So just to get to see that new technology and where it was going to take us, I was like, I want to be a part of this.
Yeah, James is a very humble guy. He was in this combo program, kind of accelerated with undergrad and med school and stuff, and he's always very humble. So
humility is good. So again, to bring the connection with everything together, then you did a fellowship actually with Dr. Pericato.
Yeah, so we were on a group together, and he was trying to recruit someone to help with recruitment. And we started talking one night, and we talked for almost like 2 hours.
Yeah.
And I was like, wow, this guy sounds just like me. I mean, he's crazy. No, but I could tell that our personalities were going to mesh. And then, the opportunity to work under him opened up at University of Florida. And then I came down and worked with him, and then we decided to join forces. And then we've been partners since then.
And again, during the course of the show, we'll talk about some of the really innovative work you guys have done with identifying the anatomic landmarks for groin pain. And so by taking that, looking at some of the pathologic changes that are common or are more common in people with chronic groin pain issues versus people that don't have those issues, you've had some landmark work which is really innovative, and how you've applied the robot to allowing a very, very innovative and very, very interesting, and I keep using that word, it's really, really forward thinking, and for me, just being able to call you guys friends because of the thought process that goes into thinking outside of the box to that level is really interesting. So we'll talk about that. And if anyone has any kind of issues with groin pain, chronic groin pain, which is a very challenging issue, call us at 904-340-1045. Again, that's 904-340-1045. And share your story and see if we can kind of help from that standpoint of things. To get back kind of to the men's health issue before we spend the rest of the show talking about groin pain, if someone wants to get involved, if someone wants to follow you guys, again, you're using the Google Glasses so people can follow in multiple different capacities. You're both very savvy on social media and Twitter. What can people do to get involved?
Well, we have multiple avenues you can get involved. One, you can join us when we launch off from South Lake Hospital in Claremont on June 12th. We're actually going to be stopping very close to here in St. Augustine. You can come and stop. You can go on our website, driveformenshealth.com, and see what the entire journey is and where we're going to be. And you can also see who the speakers are. Actually, Dr. Kazarian is actually going to be speaking at one of our stops as well. But we have 40 to 45 international experts in men's health that are going to be chiming in via live webcasts, which you can follow on our website, or live in person at our individual stops. You can also follow us on Twitter at Drive for Men. You can follow us on Instagram at Drive for Men, and we also have a Facebook page as well. So any support you can give us by just watching or coming out, or you can support us as well through our Indiegogo campaign. The whole initiative is to raise awareness, but we're also trying to raise funds, one for genetic research in chronic men's health and pain conditions, and the other half will go to student scholarships for students attending Florida Polytechnic University.
Which is an engineering group.
Yep, it's a brand new university in Lakeland, and so they're really trying to develop a new program that's integrated with industry. So we're actually potentially going to have some of these students rotating through the hospital system in our practice, kind of trying to, again, get us thinking outside the box and looking at how we treat patients now and how we could take it to the next level.
And so one thing that's really interesting, for the field of urology, and one thing that as I got into laparoscopic and robotic surgery and even endourology, when you go back and look at the history of urology, we've been fairly innovative in the use of technology to better our field. One of the coolest books that I own is a surgical atlas from the 1840s to 1860s for the entire body. And what's interesting is the urologic section, essentially what they did back then was exactly what we do now. It's just their tools were just real primitive, and I can't imagine how painful it would be, some of the things that they did without anesthesia and without antibiotics. So we took those same concepts, and through time we have made it less invasive, and our optics, our use of telescopes, our use of minimally invasive techniques are fantastic, and some of the things that you guys are doing take it to a completely different level. So I'm very excited to kind of get into talking about those. What's interesting with regards to what you guys are doing for the patients is taking those concepts and making it readily available to everyone. Now, before we go to break, tell us a little bit about your clinic, the Pure Clinic.
So the Pure Clinic stands for Personalized Urology and Robotics, and we've always felt that, the way medicine's going, that there is a growing need for, sometimes you want to spend a little more time with your doctor and sit down and talk, and we've become so technical, and with the electronic medical record systems and the documentation we have to do, it becomes stressful for the patient and the doctor because the focus shifts on, what needs to be documented, and, I wonder if it takes away a bit from that one-on-one human kind of touch and just spending some time talking to the patient. And so what we're trying to do basically is our goal is really to try to focus, spend a little more time. We actually have like half-an-hour visits. We've kind of stepped back, slowed things down, really trying to focus and make things efficient so that we actually spend more time one-on-one with the patients. What's unique too is on our off days, we have a unique system where we have clinics on certain mornings, or usually in the afternoons, and then on other days we do Skype and phone and consultations. So we try to make it easy so that, you could be at home, at work, out shopping, doing whatever, and, actually communicate with your physician. And what we've found on the internet communication is that sometimes you actually spend more quality time because, that kind of visit's a little different because there's no time being wasted for, vitals and things like that. But it's actually just, 20, 30 minutes one-on-one with the person. And it's
education for both of you. You learn about the patient learns about the disease process.
You just cannot get the whole story because sometimes, everyone's a little bit different and you just build that connection. And so our clinic's really been geared towards that, and we're small, but I think it goes to the old saying, we don't want to be the biggest, but hopefully we can be the best. So.
And again, one of the some of the things that you guys are doing on all fronts of this stuff are innovative, and the way people can get a hold of that on the web, if you want to check it out, is www.mypure.org, or they can call your clinic at 352-536-8761 again, and you can segue into some of the information that you guys have a lot on your website about this drive, Tesla Drive for Men's Health, which is fairly innovative. As we come back, we'll talk more about groin pain. If you want to call us, 340-1045, and thanks for joining us on the conversation.
Traffic alerts. For traffic alerts on your phone, text the word alert to this number, 70123. 70123. News 1045.
At our new time from 5 to 6 p.m., where we discuss the most current trends in healthcare as they relate to you. We also keep you up to date on the newest medical advances and help you stay informed on the politics of healthcare. Navigating the world of health is a challenge, and real answers are often hard to come by. Call in and have your questions answered, or just voice your opinion. Join the conversation every Saturday from 5 to 6 p.m. or visit us anytime at theconversationjax.com.
While you are off, Arlington Toyota is open all Memorial Day. And all the business, too. Sales, service, parts, collision. Arlington.
I'm joined in the studio by two good friends of mine, Dr. Cija Paracado and Dr. Jamin Brownbot, who are both microsurgeons. So they use robotic technology to do very fine microsurgery. And one of the things that they use it for is for combating chronic groin pain. And one thing I want to kind of talk about as we segue into some of the innovative work that you've done in identifying some of the anatomic reasons that this may be going on. What does the typical chronic groin pain patient present as?
So it can really range, it could start off as just a low ache or so in the testicle, ranging up to really debilitating pain radiating from the testicle all the way up to the groin. We've got a kind of a classification system that we use because it's really difficult to lump everyone together, so everyone's a little bit different, and so we try to map out the pain based on the location when we meet patients. But we're really talking about patients that have chronic pain that's been there for several months, at least 3 months. Traditional treatments of antibiotics, anti-inflammatories don't seem to be helping, and that's kind of when we kind of get involved. So. In terms of some of the treatments we offer.
And it's interesting, up to 100,000 men per year are afflicted with this ailment, and it's sometimes very challenging because our general workup is often completely benign and negative, and that becomes a source of incredible frustration for the patient and incredible frustration for the physician as well, because then we start thinking, how can we better treat them? How can we come up with options? And sometimes we don't have historically very good options. So what do you guys, say to in terms of when you see a patient who's gone through multiple different things? A lot of these, 6 to 12% of men after vasectomy have chronic pain issues in the groin. 18% of patients who've had inguinal hernia repairs have such things. 5% of people who have scrotal surgery, and even 1 to 2% of people who have abdominal surgery may have issues of this nature. When you guys are going through your workup to figure out essentially what to do, how do you take into account their individual history of what they're complaining of that you mentioned, but also what they've had done before?
Yeah, we usually start the conversation off by letting them know that they're not alone. This is a very common problem. It's a very underdiagnosed and not. A lot of our patients, on average, we counted, have seen 7, physicians before us. A lot of them are on chronic narcotics, have been on antibiotics for several months. So when they come see us, a lot of the visit is, just letting them know that, that you're not at the end of your road. There are things that we can do for you. Based on our experience, we've seen over 2,500 men now in the past 6 years with chronic groin and testicular pain. And now we have a pretty good algorithm that we follow. A lot of patients, if they're seeing us for the first time and haven't seen anybody, then we will still go through all the conservative measures that we talked about, including physical therapy or acupuncture, anything to get them to that, to say that we tried all those things. But then beyond that, we generally will start off with a spermatic cord block, where we will put some numbing medication and some steroids around the spermatic cord itself. And based on their response to that cord, we may move down to further surgical options. One of the surgeries that has been pioneered by my partner is a targeted robotic denervation of the spermatic cord, where we've done some mapping studies, and you can see our paper on our website at mypure.org, where we've kind of mapped where are the most common nerves around the spermatic cord, and there's basically 3 areas on the spermatic cord. One is the cremasteric muscle, which is basically the muscle layer around the cord. The second is around the vas, which is the tube that brings your sperm from your testicles out when you ejaculate. And the third is in some of the fat behind the cord. And we've done studies on cadavers, mapping these nerves, as well as human spermatic tissue as well.
And you guys labeled this as a trifecta nerve complex, and then you've done some elegant studies looking about 56 or so men who had chronic groin pain issues and compared them with about 10 men who did not have these issues, and you actually found some changes in the pathologic specimen and the histopathology of the nerves in those patients that had the chronic pain. So that's really, really exciting and very novel things at looking at the inflammatory process that may incite these issues. And so in this, it seems like you now are focused and are focused in targeting those nerves specifically. And we'll talk a little bit more about the details of the surgical technique. But some of your data shows a large volume of patients undergoing your techniques have up to 85% cure rates from their pain, and that is sustainable and durable through time. So hats off first, but two, that's fantastic stuff.
Yeah, and it's when we talk about even the paper and the changes we found, it really has a profound effect on these patients, because we're dealing with patients that really are kind of at the end of the line, have tried many of the treatments and failed those treatments, and they've been told that, hey, this pain might be in your head and not quite real and stuff, and so this really helps. Makes
it's amazing stuff, and it's, again, the novel use of technology and science to come up with good solutions. I think really that's what urologists do. Thanks for joining us for this half hour. We'll come into the next half an hour. Join us at 340-1045. You're on The Conversation. At the Pure Clinic, Dr. Jamie Bobman. With regards to some of the things we're talking about today, we're talking about groin pain and some very novel things that we can do to try to help patients who a lot of times are getting very, very, very frustrated and dejected because all their studies are negative, all their workup seems to not find a target for their pain, and a lot of times they are very frustrated. So some of the work that you're doing is very, very innovative. And one thing I wanted to kind of talk about is the concept of a sports hernia. I actually have some friends who, call me up and ask me, what do you think about a sports hernia? And it's a very challenging disease process. So for our audience, what are your thoughts on the sports hernia?
So I think chronic groin testicular pain comes in many different forms, and each different specialty has different ways of handling it. And the sports hernia is also a type of kind of pain with no specific, known etiology or cause. We think that it's due to some type of muscle laxity or maybe unopposed pulling of some of the muscles that are attached to the pubic bone. And so sometimes MRIs are helpful to detect these defects in the abdominal wall. But again, it's a very difficult concept to deal with, and there are some extensive reconstructive treatment options where we can detach the muscles in the groin area and reattach them. Physical therapy plays a big role. Any type of neuromodulation technique to try to kind of calm the nerves down. But what's interesting is when you look at the long-term outcomes, they're very similar to other approaches like that the general surgeons or the urologists would use for similar types of conditions in their areas. And so when you take a step back and look at all these conditions, the common theme or ingredient seems to be some type of nerve hypersensitivity. And so that's what kind of led us to focus more on treating the nerves directly rather than some of the structural defects that may or may not be there. And so that's really kind of the fundamental basis of a lot of our treatment.
Yeah, and a lot of the interventions for sports hernia, these patients are down for a long time, and getting them back up on their feet, if there's athletes, 3 months could be, they could lose a whole year of their work. So with the procedure that we do, it's an incision. It's about 2 or 3 centimeters in length, and we recommend a week of bed rest. But they're pretty much back on their feet, within a month. And some patients do take a little longer to recover. Some may take shorter. But if you look at the outcomes, if you look at our outcomes versus their outcomes, they're fairly similar, but, in our approach, it's a more minimally invasive approach, and especially for athletes when, time is, money and time is, energy for them, we want to get them back up on their feet as soon as possible.
What is your surgical technique that you do using microsurgery with the robot to treat a disease like a sports hernia?
So the concept is really we're just going after the 3 nerve branches that we mentioned before, in the cremasteric, the perivasal sheath, and the fat behind the spermatic cord. So we're just really ligating those 3 areas with a special type of laser that decreases the chance of those nerves regrowing or causing pain. And we're actually leaving the bulk of the cord intact. So that's really the big difference, is that this is a very minimalistic procedure where we really don't want to mess with anything else in the system. So it doesn't affect erections, doesn't affect sensation. You're still going to feel your testicle, but you kind of lose, or hopefully we're going to get rid of that pain that you feel like you've been kind of kicked in the nuts or so, that kind of sensation. So that's really what really defines us. Now, if that treatment doesn't work, we have some salvage treatments, something called targeted microcryoablation, and then also Botox injections into that area. And so we've got some additional treatment algorithms that are able to help the majority of patients. So overall, even if we fail with the first-line therapy, which is the targeted denervation, which gets us about an 85% success rate, in the salvage group, we're able to help quite a few of these patients, and we're able to help about 90-95% of the patients altogether with a combination of all these different types of treatments.
And again, with this for our audience, the way to think about some of the anatomic structures we're talking about, if you imagine that when you're in your mom's belly being formed and you get the genetic programming to be a male, your testicles kind of start out somewhere around, where your kidneys are, and they kind of make their way back down to the scrotum towards this canal in the groin called the inguinal canal. So when people get hernias, inguinal hernias, it's basically things from the inside of the abdomen making their way through that potential space. And if you can kind of imagine, a guy with a fishing rod and a fishing line sitting at the bottom of your scrotum pulling through to get the testicle down through, that's what happens kind of anatomically as a boy is formed in their mom's belly. The cord is the structure that brings the blood vessels that to the testicle that bring blood to and from the testicle and maintain its blood supply. Also, the vas deferens is the cord that takes sperm from the testicle to back into the body where it can expel and with an ejaculation contribute sperm, and it's actually the target of the vasectomy. So in the study that you did, you actually went through with very elegant cadaveric studies where you guys did micro dissection of the nerves in that area and found the areas that have the nerve. And then in that study that we mentioned, which was a landmark study in the Journal of Urology in July of 2013, you looked at the pathologic changes in that area, comparing normal people that don't have groin pain with people that have the chronic groin pain, and you found some of those changes. So now you target those areas in your surgery in a very beautiful algorithmic manner, which again, I keep talking about it, but when I was reading the study the first time, and again for this show, it's really innovative stuff, and it's very fun to see people think out of the box to do things that then translates to such great cure rates for people that are very challenging patient population to deal with. Surgically, when you were developing the surgical technique of how to go about this, what were some of the concepts that you were looking at to figure out? I mean, you dissect out the spermatic cord and you're looking at it. How to even begin to find these things? How did that play out?
I think a lot of it came from learning about a lot of the existing procedures. So we definitely learned from techniques that the sports management specialists utilized with some of the sports hernia repairs, what urologists do with the classic denervation procedure. And then we copied a lot of elements from plastics and peripheral nerve surgeons. So sometimes talking and communicating, exchanging ideas with surgeons from other fields is tremendously valuable as well. And we're part of a group called RAMSES, the Robotic Assisted Microsurgical Endoscopic Society. And this is a group of microsurgeons from around the world. We're all pushing the envelope a bit, but the idea is, you learn a lot about how other specialties treat nerves and nerve injuries. And so we've incorporated things like, for example, we put a protective wrap around the cord to decrease the chance of neuroma formation after the surgery. Those are concepts that were developed by the peripheral nerve surgeons. And so, yes, we did a lot of work in terms of putting this all together, but a lot of these concepts were already in existence, and we've just kind of put them together for this particular application.
Even the spermatic cord block we do was based on our discussions with anesthesiologists and pain management specialists, and what do you put in it, and we tested out different basically different cocktails of it, and we found something that worked. So it's looking outside the box, not just talking to each other or fellow urologists, is talking to other specialties, and not trying to reinvent the wheel, but trying to improve on what's already there.
So what would you say, as a call to arms for gentlemen out there who are dealing with this and maybe getting a little bit frustrated, what would you suggest that they do?
Well, it's important to first of all give them assurance that it's not really them. I mean, there's a lot we don't understand about this pain, so it's not that they did something wrong or that they're crazy or anything like that. This is real, and it's very debilitating. What's interesting is we use this thing called the PIC-6 score to measure how much it impacts their quality of life. And when you compare that, it's a standardized score compared to patients who, for example, have chronic arthritis or back problems or Crohn's disease. The impact of testicular and groin pain is actually surprisingly even more impactful on their quality of life than some of those chronic conditions. And when you put it in those terms, it really gives them validation that, hey, this is real. But it's tough for the patient and the patient's family too. It takes a real strain on the patient's entire group. So the best advice is for the patients to reach out and find a physician that they feel comfortable talking to, not to give up. I know, it's an area, a topic that a lot of physicians are uncomfortable talking about or dealing with, but there is help. There are, a few places around that do support these men, and there's a lot of online resources. There's online blogs and support patients. You can usually find a lot of other men online that have similar conditions and issues, and that helps kind of decrease some of the anxiety. And then, of course, we'd always be glad to help out with anyone who has any issues, and we do Skype and phone consults and things like that are very discreet and private. And so, because these are topics that, are difficult to discuss.
It's very difficult to discuss.
And so sometimes, it's not something that people want to advertise. And so, I always tell Jamin that, it's unfortunate, we're not like the orthopedic surgeons who get a lot of promos and stuff, and the patients are very proud to show, hey, this is what they did to me, but this is an area that we kind of hide a bit, and it's a secret wink, and it's like, he's my doctor, but I can't talk about it.
That's funny. I'll tell you one thing. Let's talk about on the flip side of ththings. Women with groin pain. What is the difference between that disease process? It's a very challenging process.
Yeah, we're seeing a lot more women. I'm treating a lot of women with that have these diagnoses of quote-unquote interstitial cystitis or chronic pelvic pain or pudendal nerve disorder. And, a lot of the nerves, anatomically, embryologically, we have the same structures and the same nerves. You mentioned the spermatic cord going down, but women have, some of the same structures and same nerves going down, they just didn't have the testicle. So what we're doing is we're kind of using a similar algorithm. We're starting off with a block. We would do a block in the groin area, we've had several patients we've done where we would actually do something similar to a denervation in that area. In the groin, just like we would do in men. And, we've had fairly high success rates. Some of the other things that we're doing is using neuromodulation, basically a pacemaker for the bladder, to see if that would help some of their pelvic symptoms.
Similar to InterStem, it's just you apply it slightly differently with a different knowledge base of the nerves affecting the area in question.
Exactly. We've also used it for some kind of innovative applications, like patients have had amputation and kind of have some referred pain or phantom pain in the area. Some of our techniques have helped with those kind of really complex situations. So there's a lot that we still don't understand too, and a lot that is to be learned.
Let me ask you, women with groin pain, how do they present?
It's very similar. They're saying they're having this pain in the groin, and it's not much different than how men present. They just have this chronic pelvic pain, and they've had cystocell repairs and repair obviously would rule out anything anatomically that's causing their pain, just like we would do in our men. But it's a very similar presentation. We kind of use the same algorithm, and we use the same mapping that we do to kind of classify them, just like we do our men.
We had a few women who presented after hernia repairs. It's not very common in women, but some women do have that and have had issues. And then also like femoral hernia repairs, which is even rarer. But it seems like the common theme is some type of irritation of the ilingual, the abdominal nerves or something of that nature.
Let me ask you, from the lessons you've learned from the anatomic studies that you guys have done and the understanding you have now on the other side of treating patients who have chronic groin pain, how do you guys handle the tissue differently in people for other cases that you're doing that don't have groin pain? And this is one out there for the surgeons listening.
Well, I think we do work with pain management specialists, and one of the things that we've started doing differently is our medication pre-op protocols and how, Jamin could probably kind of talk about it a little more.
We take a whole body approach to it. We don't just focus on the surgical aspect. Our patients, after surgery, we do give them like a Neurontin or gabapentin, something to help with neuroblockade. We give them anti-inflammatories. At the same time, we also check their B12. So to check if they're B12 deficient. We check their testosterone. We were still always searching. Like, is there something else that we're missing that could be causing their nerve pain? And B12 deficiency is very common. And so we now check B12 on everybody, and if they're not, at the 1,000 point, which is recommended, we will supplement them as well. So we don't just focus on the surgery; we try to take a whole body approach.
With chronic pain, especially these patients are very high risk for developing worsening of the pain, with any type of surgical intervention. So what we do is really try to block all the pain pathways. We give them Tylenol, Celebrex, Neurontin, basically different medications to block all the different ways that pain could respond. And that way, if we can block that even before we make an incision or do anything, maybe that will lead to less pain afterwards.
Any advice to us urologists in terms of how we handle the tissue?
Obviously, the less manipulation, the better, and the more pre-blocking and,
It's a challenging disease process because, again, most of us handle these tissues with the utmost delicacy, and the instruments that we use focus on being delicate. And still, again, I think the genetics work that you guys are going to do is going to be groundbreaking because it'll let us know.
Yeah, and I think urologists are handling tissue well. It's just more education for the patient. Like, we see a lot of patients with post-vasectomy pain. Now, post-vasectomy pain, if you look at the literature, 5 to 10% of patients that get a vasectomy will have some chronic pain afterwards. Where about majority of the patients we see were never even told that this is, something that they could get. So really just, educating the patient better on some of the potential risks of these procedures, I think, would be more powerful.
And I think, unfortunately, it's also maybe got less to do with the technique, but more, we think, may have a component with how the patient's nerves behave. There may be something different about these patients compared to patients don't develop pain.
And that's something that we have to work more to learn.
Yeah.
And one more segment, WOKV. This is a conversation on News 104.5 WOKV, and we've been blessed to kind of talk about groin pain, a very interesting topic. And when we come back, we'll finish up with that and talk about the Tesla Men's Health Drive and how you can get more involved in that. Some innovative landmark work has been done in the anatomy and the pathology of groin pain with my good friend Dr. C.J. Pericottle and his partner in crime from the Polytechnic, which is Personalized Urology and Robotics, Dr. Jamin Brombat. Thank you guys for joining me today. It's been an absolute pleasure and a thrill to, one, get to hang out with you guys and learn about some of your innovative work. Once again, I want to kind of talk about the Men's Health Drive with Tesla that you guys are doing. What are some things to leave our wonderful listeners that want to get involved?
So, Lee, just like we're having a conversation here, that's what we're trying to do for men's health on a global scale.
What a segment! That's professional work.
Men just don't want to talk about issues like we're talking about today, chronic groin testicular pain. We're trying to change that. We're trying to start a conversation because men have a 5-year less life expectancy. We're more likely to die of heart attacks and blood clots and all the other all the things that.
And we don't go to the doctor.
And we go to the doctor. And we're trying to change that through this drive. So we're using cool technology. My partner's Tesla. We're driving all the way up to New York, and we have about 40 speakers that are going to be talking live via webcasts. And you can follow us on driveformenshealth.com, or you can follow us on our social media feeds. But it's all about starting that conversation to get guys like us to just go see a doctor and take better care of themselves.
So if anyone here in St. Augustine can come join us, we'll be at the supercharging station in St. Augustine. It'll be on Thursday morning, June 12th. Please go to our website, again, driveformenshealth.com. And, Dr. Kasryan's going to be there. And so, this is going to be awesome. And we've got a few of the speakers and some demos of some new technology out there.
And so you tell me I have 7 minutes to speak?
Yeah, exactly.
We'll give you 8.
Talk about it. So a little more than this segment.
So it'll be a little bit more than the segment, so we're going to be in trouble when we go into. So now, a couple things for us to talk about before we go out. One of the things I learned this weekend that was a little bit challenging to take in was Dr. Pericottle's fondness for Katy Perry. So do we want to talk? I've seen her in concert, and I went like kicking and dragging, but it was probably one of the most amazing concerts that I personally have been to. How did this happen?
The man loves Katy Perry. He listens to it in the OR. We're actually on our website. You'll see he's made a video pleading Katy Perry to come to our Drive for Men's Health. He's just in love with it.
Where can we see this video?
This should be released soon. So Jamin's been hoarding it, but basically on our website, each day from June 1st to June 12th, we're going to be releasing short video snippets, and that will be one of the snippets. So please visit our website each day. And if
can she come to the St. Augustine one?
That would be awesome. She
can drive with us in the car if she wants the entire way up. We will make an exception for her.
She may want to hang out with me and watch it on Google, probably, is my suspicion. So I will add to you guys, the conversation would very much like Katy Perry to come to the Tesla Drive for Men's Health, and preferably the St. Augustine showing. And I'll try to do the best talk I've ever given, if that's the case. Again, thank you guys so much for coming on the show. And raising awareness for men's health, that's one of the things that we're trying to do our best to get guys to check out themselves and remain more healthy. So in your honor, Dr. Pericottle, we will leave the show with Katy Perry, and I believe that this is a song that you guys will be taking off from Claremont with.
This is our theme song, yeah.
June 12th, 8:30. Follow us at driveformenshealth.com.
And thank you for joining us on The Conversation.
I let you push me past the breaking point. I stood for nothing, so I fell for everything. You held me down, but I got up. Already brushing off the dust. You hear my voice, you hear that sound. Like thunder gonna shake the ground. You held me down, but I got up. Get ready, 'cause I've had enough. I see it all, I see it now. I got the eye of the tiger, fighter, dancing through the fire. 'Cause I am a champion.
This is News 104.5, streaming live at WOKV.com. WOKV Jacksonville, WOKV FM Atlantic Beach.
Hi, I'm Dr. Ali Kasryan. Join me on The Conversation every Saturday at our new time from 5 to 6 p.m., where we discuss the most current trends in healthcare as they relate to you. We also keep you up to date on the newest medical advances and help you stay informed on the politics of healthcare. Navigating the world of health is a challenge, and real answers are often hard to come by. Call in and have your questions answered, or just voice your opinion. Join The Conversation every Saturday from 5 to 6 p.m., or visit us anytime at theconversationjax.com.
If you're thinking of selling or trading in your vehicle,